In this lesson, we'll discuss urinary tract obstruction. There are 4 parts in this section, including introduction, hydronephrosis, urinary retention, benign prostatic hyperplasia. Since the urinary system itself or surrounding tissues with lesions in the structure or function, resulting in urinary channel obstruction, and the urine cannot be properly discharged, urinary obstruction can lead to proximal urinary tract dilation, urine retention, even renal function impairment. Urinary tract obstruction can be divided into upper urinary tract obstruction and lower urinary tract obstruction. In upper urinary tract obstruction, obstruction occurs above the urethral orifice. It can cause the dilation of the upper urinary tract and have a great influence on the ipsilateral renal function. In lower urinary tract obstruction, obstruction occurs in bladder and below, and the influence on renal function is demonstrated slowly. In renal obstruction, the most common etiology is the congenital lesion at uretero-pelvic junction. In urethral obstruction, the most common acquired etiology is calculus. In bladder obstruction, the most common reasons are benign prostatic hyperplasia and prostate cancer. In urethral obstruction, the most common cause is urethral stricture. Upper urinary tract obstruction can increase renal pelvic pressure, cause glomerular filtration rate, and kidney blood flow decrease. It can influence the renal tubular function, leading to the renal unit sodium transport capacity decrease and the renal concentration and secretion function decline. In lower urinary tract obstruction, to overcome the obstruction, detrusor becomes thickened. When decompensated detrusor appears, loss of detrusor contractility, detrusor instability might occur, and the major manifestation is chronic urinary retention, even overflowing incontinence and renal function impairment. When urine is blocked from the discharge of the renal pelvis, the pressure in the kidney increases with urine accumulation, and the renal pelvis and the calyx dilate, leading to the renal parenchyma atrophy and reduced function. This condition is called hydronephrosis. The volume of hydronephrosis exceeds 1,000 milliliter, or the daily urine volume in children, is called giant hydronephrosis. Due to the variant etiology, location, severity, and duration of obstruction, the clinical manifestation of hydronephrosis are different, even asymptomatic. The patient with acute obstruction may have renal colic, nausea, vomiting, renal tenderness, and hematuria. The patient with chronic obstruction may only have lumbar dull pain. Severe obstruction can cause renal insufficiency, presenting with anemia, anorexia, and uremia. The patient with infection can have rigor, fever, dorsal gear, and bladder irritative symptoms. Imaging examinations for the diagnosis of hydronephrosis include ultrasonography, excretory urography, CT, MRI, and renal scintigraphy. CT urography is commonly used, has an important role in the diagnosis of hydronephrosis. Because hydronephrosis is caused by urinary tract obstruction, and the duration of obstruction play an important role in the influence on renal function. Eliminating the cause of obstruction is curative and most important. If the patient is in a critical condition and the cause of obstruction cannot be immediately eradicated, percutaneous nephrostomy or urethral stenting can be performed to protect renal function. Nephrectomy should be considered in the condition of severe hydronephrosis, renal hypertension, or severe infection associated with the loss of ipsilateral renal function and the normal contralateral kidney. Urinary retention denotes that the bladder is full of urine, but the urine cannot be emptied. This is usually caused by the progressive bladder outlet obstruction and bladder decompensation. The etiology of urinary retention can be classified into mechanical and dynamic obstruction. The reason of mechanical obstruction includes benign prostate hyperplasia, prostate cancer, bladder-neck contracture, bladder-neck tumor, urethral stenosis, urethral-calculars, and pelvic tumors. The cause of dynamic obstruction comprise central neuropathy, peripheral neuropathy, surgical injury of parasympathetic nerve, spinal or epidural block anesthesia, and medicines. The patients with acute urinary retention can have dysuria, lower abdominal pain. The patient with chronic urinary retention can have frequency, urgency, dysuria, incomplete emptying, and incontinence. The diagnosis can be based on typical clinical manifestations and ultrasonography. Physical examination shows a spherical bulge in the suprapubic area, with obvious feeling of urination as being pressed. Ultrasonography can show the filling bladder. Anuria must be excluded in patients suspected with urinary retention. It is called by renal failure or complete upper urinary tract obstruction. In this condition, there is no urine in the bladder. For acute urinary retention, elimination of the cause is the most important. If the cause is unknown or the obstruction is difficult to remove, catheterization, percutaneous cystostomy, bladder puncture, and urine drainage should be performed. In chronic urinary retention, for mechanical obstruction, drainage of the urine and eliminating the cause of obstruction are necessary. For dynamic obstruction, intermittent self-catheterization and suprapubic cystostomy might be reasonable. Benign prostatic hyperplasia is the most common benign disease among the causes of lower urinary tract obstruction in the old male. There are two major etiological factors responsible for benign prostatic hyperplasia. The first is aging. With the increase of age, the prostate also proliferates. Men may have different degrees of prostate hyperplasia after 45 years old. And the clinical symptoms usually appear after the age of 50. The second is functional testes. The normal development of the prostate depends on androgens, and the imbalance of sex hormone in the body with aging may be an important cause of prostate hyperplasia. The prostate can be divided into three parts, including transition zone, central zone, and peripheral zone. Benign prostatic hyperplasia mainly occur in the transition zone, but peripheral zone is the largest. In benign prostatic hyperplasia, compensatory hypertrophy of detrusor occurs, resulting in the increase of contractility, trabeculation, and the pseudo-diverticulum in bladder wall. Unstable contraction of the detrusor can cause the increased resistance to lateral urine discharge and the resultant dilation of the upper urinary tract. Long-term hydronosis can lead to impaired renal function, and urinary retention in bladder can cause the secondary infection and the stone formation. Frequency is the most important early symptom of benign prostatic hyperplasia, which is more obvious at night. Dysuria is the most important symptom of benign prostatic hyperplasia. The disease progresses gradually, and there's often a feeling of incomplete emptying at the end of micturition. When benign prostatic hyperplasia is complicated by infection or calculars, frequency, urgency, and dysuria may become more severe, and painless hematuria may also occur. The diagnosis can be made based on the typical clinical manifestations and the digital rectal examination, serum prostate-specific antigen, ultrasonography, and uroflowmetry. Dysuria caused by benign prostatic hyperplasia should be distinguished from the following diseases, such as prostate cancer, bladder-neck contracture, urethral stenosis, and neurogenic bladder. Conservative treatment or surgical intervention can be considered according to the condition of patients with benign prostatic hyperplasia. In conservative treatment, watchful waiting can be used in those with mild symptoms and without significant influence on the quality of life. Medical treatment include alpha-adrenergic antagonists and 5-alpha reductase inhibitor. Surgical treatment usually include transurethral prostatectomy and laser ablation or enucleation of the prostate. At present, the former is still the gold standard for the treatment. The indication of operation include severe obstructive symptom, residual urine volume over 50 milliliter, recurrent urinary retention, and recurrent urinary tract infection, secondary bladder stone, secondary hydronephrosis, and failed conservative treatment. That's all. Thank you for your attention.